Hi, welcome to the NEET PG Core Revision series in Pharmacology, where I will be discussing the important topics for the upcoming NEET PG examination. So, we are going to do today diuretics. So, first, let's see the target sites of the various diuretics. So, this is right. So, you can see in the nephron, here we have the cortex, and this is the outer medulla. So, starting from the proximal convoluted tubule, so the first site or on the PCT itself, the diuretics which act are the acetazolamide, right? So here the acetazolamide act. Then osmotic agents like mannitol also act on the proximal convoluted tubule, but alongside they also act on the descending loop of Henle, right? So here somewhere in the loop of Henle, so they act here as well as on the PCT. Loop as the name suggests, the loop diuretics, they act at the level of the thick ascending limb of the loop of Henle. Thiazides, they act on the distal convoluted tubule, and then we have the potassium sparing diuretics which act on the collecting tubule. Then we have the ADH antagonists also which work at the level of the collecting tubule. So for the diuretics, if you want to remember them according to their site of action and in this manner, so you remember a mnemonic which is called COLTS. So first it is carbonic anhydrase inhibitor, then we have the osmotic diuretic, then we can remember the loop agents, then we remember the thiazides, and then we have spironolactone. So moving on to the important features or points I'm going to do in comparison, a tabulated form. How can we compare them? It is very easy therefore to understand and also to form a memory of it. So we have carbonic anhydrase inhibitors like acetazolamide. So we have carbonic anhydrase inhibitors which are topical also like dorzolamide, brinzolamide that we use in the eye in the cases of glaucoma. Osmotic diuretic we have mannitol and glycerol. Loop diuretics furosemide, torsemide, bumetanide. In the thiazides, a longest acting apart from hydrochlorothiazide we have chlorthalidone. Right, so this is the longest acting. Now, in the potassium sparing diuretic, remember the mnemonic EATS. So, E stands for eplerenone, A is amiloride, triamterene, and S stands for spironolactone. So, these are the potassium sparing diuretics. The site of action should be in the proximal convoluted tubule, and the target is they inhibit carbonic anhydrase. Okay. Now, the next is osmotic diuretics. The site of action is PCT and in the descending limb of Henle. Target is they are going to basically work by the osmotic process. So, they draw the water by osmosis. So, they will enter inside the kidneys in the lumen and they will draw the water by osmosis, and this will lead to a solute free water loss. So, it's more water, less of solute. So, solute free water loss. The third, the loop diuretics, they act at the loop of Henle. So, ascending thick limb of loop of Henle. What is the target site? So, they are going to inhibit sodium, potassium, 2-chloride sympota. So, they also, apart from this, they are going to increase the renal prostaglandin synthesis. So because of this, they are going to enhance the renal hemodynamics, vasodilatation and all they cause. So this is another important thing, because that's why if you give them along with the non-steroidal anti-inflammatory drugs, they are going to inhibit the prostaglandin synthesis. So therefore, they will blunt the action of these diuretics. Then we have the thiazides. Thiazides, where do they act? They act at the distal convoluted tubule, and what they do, they inhibit the sodium chloride symporter. Okay, again, they are also going to enhance or increase the renal prostaglandin synthesis. Last, we have the potassium sparing diuretics. So they are going to target the collecting tubules. Remember, all the other diuretics, they are going to act through the lumen of the diuretic. So what I mean when I say this, so let's say this is the nephron, and all the other diuretics, they are going to first enter inside the lumen and then they are going to have their action. This is the only diuretic which is going to act from the luminal side, right? So here it is going to act somewhere here. So on the CT, but this is going to act from the basolateral side, outside, basolateral side. Okay. Now, the target for this is, there are two targets here. So the first group of drugs, they are aldosterone antagonists. Aldosterone antagonists. In this we have spironolactone and eplerenone, finrenone, all those drugs. Number two, these are the drugs which are going to inhibit the epithelial sodium channels. Epithelial sodium channels inhibitors. So what are these drugs? These are your amiloride and triamterene. So remember, one is aldosterone antagonist, the other one is epithelial sodium channel inhibitor. Both are going to work in a similar manner and they are going to cause increase in the potassium levels. Major side effects now, let's do. So major side effects of the first group, which is estazolamide or carbonic anhydrase inhibitors. The most important is it can cause metabolic acidosis. Now, 25% of the sodium is reabsorbed in the proximal convoluted tubule, but this is not allowing the absorption. So most of the sodium is going to be now retained or reabsorbed at the level of the last part in the collecting tubule, and in exchange a lot of potassium is going to be given out. This group of diuretics, they are going to cause maximum hypokalemia. So hypokalemia and maximum hypokalemia amongst all these diuretics. Then they can cause rashes, right? That is very important, and they can lead to renal stones. The second one, which is the osmotic diuretics. So pulmonary edema is one of the, can be a drawbacks, and if pulmonary edema is present, it should not be given in that condition. Loop diuretics. So loop diuretics and thiazides, they almost they share the similar, you can say, the side effect profile, except for one difference. So both of them, we can say, if I talk about both of them, right? So they are going to cause low PMC. The difference is low potassium. So they are going to cause hypokalemia. Low magnesium. But for the calcium, loop is going to cause calcium, but in the case of thiazides, they are going to cause high calcium levels, right? So remember, loop loses calcium. That means it is going to cause hypocalcemia, while thiazides are going to retain calcium. So they are going to cause hypercalcemia. That's the only difference right here. And they are going to cause, loop is low is this, and high glue. Remember, low PMC, high glue. High glue means hyperglycemia, hyperlipidemia, hyperuricemia, high uric acid. Right? So these are the important, you can say, the drawbacks. Only please remember that this is the difference between thiazides and loop diuretics, that the loop diuretics are going to cause hypocalcemia while the thiazides are going to cause hypercalcemia. Then another important, only restricted to loop diuretics, would be ototoxicity. Ototoxicity, and that too with the drug ethacrynic acid, not with thiazides. Ethacrynic acid, it is no longer used now because of this, so but it's one of the loop diuretics. So moving on to the last group here, that we have the potassium sparing diuretics. So obviously they're sparing potassium or keeping potassium inside the body. What will they do? They will lead to hyperkalemia. So their drawback is hyperkalemia. The spironolactone has an additional drawback. It can cause gynecomastia, but this is not seen with eplerenone. So you can see gynecomastia, it is seen with spironolactone. So eplerenone does not have this action. Then it can lead to acidosis, right? So these are the important side effects that we, in a comparative fashion amongst all these diuretics. Now, some important one-liners from here. Which is the most potent loop diuretic? That is bumetanide. Bumetanide. So loop diuretic with the longest half-life, torsemide. Highly ototoxic, ethacrynic acid. E for ear and E for ethacrynic acid, ototoxicity. Diuretics which can be used in renal failure. So one we can use loop diuretics. And the only thiazide which can be used is called as metolazone. Thiazides used in calcium stones. So these are the renal stones. So if there is increased calcium in the urine, we need a drug which doesn't throw more calcium in the urine, rather retains the calcium. So we have thiazides. And maximum hypokalemia is caused by which we already discussed. These are your carbonic anhydrase inhibitors or estazolamide, if they ask you the question specifically. Now, the other comparators we have are the uses. So let's do the uses of these. So firstly, the estazolamide or the carbonic anhydrase inhibitor, it is a drug of choice in case of mountain sickness. Now, it can be used for prophylaxis as well, and it can be used for treatment as well. But the first or best thing when there is acute mountain sickness is to get the patient down. It should descend first, and then treatment should be started. That's the first major thing that you can do. The other uses is glaucoma. So systemically estazolamide is used in case of narrow angle glaucoma, but then we have topical carbonic anhydrase inhibitor like dorzolamide, brinzolamide that can be used in glaucoma. So it is used in case of glaucoma. It can be used in case of urinary alkalinization, right, and in case of catamenial epilepsy. Mannitol Mannitol is a drug of choice for cerebral edema, can be used in cerebral edema. Also, it is used in other conditions like in case of acute congestive glaucoma. Acute congestive, it's not a drug of choice, but yes, it can be used. Acute congestive glaucoma. And number 3, it can be used in dialysis, disequilibrium syndrome. Loop diuretics now. Now, loop diuretics are a drug of choice where number 1, in case of pulmonary edema, right, seen with left ventricular failure. In case of renal insufficiency, so when the GFR is more less than 40. So these are effective even if the GFR is less than 40. Number 3, in case of hypercalcemia of even malignancy. So what you can do is you have to give a drug because it causes hypocalcemia. It will lose the calcium. So therefore it can be given in hypercalcemia of malignancy. Thiazides are a drug of choice in case of when there is hypertension along with edema. They are useful here, and they are useful or drug of choice in nephrogenic diabetes insipidus. Then where else can it be used? In case, remember, if there is less GFR or GFR is less than 40, then this is ineffective. So remember, it is ineffective in renal insufficiency. Ineffective in renal insufficiency. Then it can be given in case of hypercalciuria. So there is stones, more calcium in the urine. So you want to give a drug which doesn't give away calcium in the urine, rather it will retain calcium. So this is a drug which retains calcium, can be given in hypercalciuria. Then we have the potassium-sparing diuretics. Where are they used? So there are drug of choice in number 1. One is called as cirrhotic edema because there is a lot of aldosterone present here. Number 2 is Conn syndrome, which is also called as hyperaldosteronism. So where there is more of aldosterone in the body. Then we have resistant hypertension. So the patient is resistant to at least 3 antihypertensive drugs. One of that must be a diuretic. So can be given in resistant hypertension also. It is used in these conditions. Very important. Then amiloride. It is the drug of choice in case of lithium induced diabetes insipidus. Okay, that is the important role. Contraindications of them. So the first, carbonic anhydrase inhibitors, because it can cause acidosis. So metabolic acidosis remains a contraindication. In case of hepatic failure, osmotic diuretics, they're absolutely contraindicated in case if there is any kind of intracranial bleed or hemorrhage. So in case of cerebral edema, you have to rule out whether there is an intracranial bleed or hemorrhage. If there is, then we cannot use them until the bleeding stops. And it can trigger pulmonary edema. So therefore, pulmonary edema conditions, we should not be giving this drug. Then contraindication of loop diuretics or both rather that they are contraindicated in patients of gout. That is important because they cause increase in the uric acid levels. Thiazides as such, They are contraindicated in case there is a lower GFR, renal insufficiency. They're contraindicated, right? So that additional, where loop diuretics are preferred in such cases. Then in case of potassium sparing diuretics, definitely if there is already cautious use, rather cautious use with other drugs that retain potassium, right? ACE inhibitors, ARBs, they are quite often employed in case of heart failures along with spironolactone, but then you have to keep on monitoring the potassium levels because both have a tendency to cause hyperkalemia. So rapid fire or very, just one important liners out of them. So what we should know, diuretics used in nephrogenic diabetes insipidus. Which diuretic is used? The diuretic used is thiazides. Thiazides. In cirrhotic edema, as I told already, this is it has a lot of aldosterone present. So the drug we will use is spironolactone. Diuretic of choice in pulmonary edema, we have loop diuretics. But the diuretic which can cause pulmonary edema, that is your mannitol. Read the question carefully, what they're asking. Diuretic of choice in cerebral edema, acute congestive glaucoma, again remains your mannitol. And diuretic used in lithium-induced diabetes insipidus, we have amiloride. Okay. Now, two questions from the previous years. Let's discuss. A female patient suffered a head injury due to road traffic accident and was found to have elevated intracranial pressure on examination. Which of the following diuretics is the drug of choice for reducing the intracranial pressure in this condition? So it's very simple here. They have increase in the intracranial pressure. So there can be edema or some cause. And what do we use in such a condition? We use mannitol, the best drug. Only thing you have to be careful if there is intracranial bleed or not. If there is an intracranial bleed, then we cannot be giving this drug. So a patient with gout and elevated uric acid levels present with hypertension also, which of the following medication should be avoided in the patient, right? So there is hypertension, yes, but there is increase in the uric acid level. So definitely any drug which will further cause a retention of the uric acid in the body should not be given. So thiazides and loop diuretics, they cause the retention. Therefore, hydrochlorothiazide is contraindicated, or it is not supposed to be used in this particular condition. So then we have a few lines about the antidiuretic drugs. So antidiuretic drugs, okay, so like ADH, antidiuretic hormones, they are the analogs of that. So we have these two antidiuretics or the vasopressin. We have two receptors, V1 and V2. So V1 is mostly concerned with vasoconstriction and platelet aggregation. Platelet aggregation. Then the V2 is present in the collecting duct, and this is responsible for the kidney actions, right? On the renal, whatever action on the renal system. So the agonist, we have some agonist and we have drugs which are the antagonists. So agonists are going to work like the antidiuretic hormone. So where do you think they can be used? Now, because this property actually of V1, vasoconstriction, has been employed in cases of bleeding, esophageal varices. So terlipressin, drug of choice for bleeding esophageal varices. Desmopressin is a drug which is used in case of central diabetes insipidus. In case of central diabetes insipidus, because what is happening is there may be lack of the antidiuretic hormone, so they are going to function like them. They are agonists or analogs of them, and they are going to stimulate the V2 receptors in the kidneys. That's the role. Central diabetes insipidus, number one, and then they can be used for nocturnal enuresis, especially in children, bedwetting at night, so that can be prevented. Now, what happens is the ADH, if there is too much ADH, and that can lead to syndrome of inappropriate ADH secretion, and when it's too much of ADH, that's antidiuretic hormone. So there is a lot of water retention in the body, and that can ultimately lead to dilutional hyponatremia, right? So we need to give the antagonists, V1 and V2 antagonists. V1 antagonist we have is relcovaptan. So these all have vaptans in them. Then we have relcovaptan, we have TLMC. So we have tol, vaptan, we have lixi, vaptan, then we have moza, vaptan, and we have coni, vaptan. So all the above three, they are oral, and coni vaptan is given by the IV route. So now, what are the important drugs for diabetes insipidus that you need to know? So the first drug is the drug for neurogenic or central diabetes insipidus, which is nowadays, that is desmopressin. Desmopressin. Nephrogenic diabetes insipidus, because here there is problem in the receptors. If the ADH is normal, but the receptor is a problem, so therefore you cannot give any drugs like desmopressin because they won't be responsive. So here we give drugs which work by any other mechanism like thiazides. Then lithium-induced diabetes insipidus, it is amiloride. So these are the important points that you must know from this topic of diuretics and antidiuretics. Thank you so much.